Hello and welcome back. In this portion of the lung ultrasound teaching program, I would just like to go over lung aeration and interstitial syndrome. So to begin with, we're just going to review the landmarks and artifact patterns that we've discussed in some of our other sections. So just as a reminder of the ultrasound landmarks and artifacts that we are looking to visualize and interpret during our lung ultrasound assessment. I've said it a few times before, but just for review, we're looking for the pleural line because all of our artifact patterns are generated from visualization of the pleural line. In order to be sure that we are actually on the pleural line, we must make sure that we've found that bat sign, which includes a view of the rib shadow above and a rib shadow below between the two rib spaces that you are investigating. If we're looking for movement of the pleural line, just as a visualization, we're looking to try and decrease our depth and try and visualize the very white hyperechoic line that is generated from the opposition of the parietal and the visceral pleura against one another. Some of the artifact patterns that we're looking to identify, I've already mentioned about the pleural line with the pleura sliding between the visceral and the parietal pleura, but we're trying to visualize the A lines that we might see in a normally aerated lung, which is just a reverberation artifact of that pleural line throughout the aerated lung field underneath. Generation of B lines are going to be quite important for us during this discussion today because we're looking for the horizontal, we're looking for the vertical lines that are generated off of the horizontal surface of the pleural line. And these artifact patterns should be consistent with the movement of the pleural line. And the amount and distribution of the B lines are going to be very interesting for us during our interstitial syndrome discussion today. In addition, the other landmarks that we might want to identify, especially if we're looking for some type of consolidation in our dependent lung regions, we want to very clearly try and identify where the diaphragm is, both left and right. It's easier to identify the diaphragm on the right-hand side because the liver makes an excellent lung window. And if we had a normally aerated lung, we might find that the curtain sign comes across, which is the aerated lung tissue coming across in front of the diaphragm and obstructing our visualization of the diaphragm. In regards to the lung ultrasound pathologies that we might want to identify, in previous discussions we've discussed about pleural effusions and pneumothorax. Today we're going to talk a little bit more about consolidation and the precursors to consolidations, which is our B-line generation. So just getting started with our interstitial syndrome. As a reminder, the evaluation of our suspected lung pathology will be guided by the clinical suspicion to undertake the diagnostic process with our lung ultrasound scanning technique. So just really looking at a systematic exam, whether you're looking at a very quick exam, which is 4 lung regions at your upper apex on the anterior chest wall, and also then down at the dependent lung regions just above the diaphragm. We could increase the zones that we're examining depending on the pathology that we're looking for, making sure that we're consistent right to left. It might look something like this. So scanning techniques, making sure that, for example, if we're looking at suspicions of a pneumothorax, for example, we'd look at least dependent lung regions and start scanning immediately from the apexes. If we have suspicions of something like a pleural effusion, we might start to scan down in our dependent lung regions near our diaphragm area. In regards to interstitial syndrome, I think the most important scanning technique to undertake is just that you're systematic and that you are looking at as much of the lung region as possible, because the quantity and quality of the B lines or changes in the aeration patterns that you might be seeing in the lungs are going to help to guide some of the clinical decisions that you might make off of that lung ultrasound exam. So in regards to interstitial syndrome or consolidation or aeration, however you want to call it, I'm looking to include more lung regions per lung, so an 8 or 12 lung region systematic exam right to left will give you a better indication of some of the pathology that's going on there. Guiding your lung ultrasound systematic exam, the blue protocol, which I've mentioned on a few separate occasions, can help to guide what you're looking at. So in this morning's presentation, we're going to be looking more at probably from the lung sliding to the B profile, pointing us probably more towards the pulmonary edema aspect, or also looking at this AB, AB or C, which is our consolidation, or our B prime profile, all of which are indicating more towards our decrease in aeration of the lung tissue and increase in fluid within the lung itself. So in regards to the systematic exam with the lung ultrasound, I mentioned briefly before when we were undertaking the exam that the location and magnitude of the artifact patterns that you're seeing, which is really a generation of the distribution between the air and water changes that you're observing within the lung, are going to help to guide us more towards those clinical decisions that we could be making. So pleural syndrome is just kind of a general term that is going to indicate more of the presence of fluid, air, or abnormal tissue that you might see within the lung. And it can include things like pleural effusions and pneumothorax, but we can break that up also into what we would call interstitial syndrome. So interstitial syndrome in regards to lung ultrasound refers more to an increase in the amount of fluid that we're seeing within the interstitium, the artifact patterns that we're seeing with our lung ultrasound, and a reduction, therefore, in the air that we're seeing within the alveoli. And clinical causes of this might include like edema, so fluid overload, fluid within the alveoli itself. Fibrosis can also give us a indication of these B lines that we're starting to see because of the changes in the artifact patterns that are being generated from from the lung ultrasound itself. And then interstitial pneumonia can also be an indication, can be indicated by this type of pleural syndrome that we're seeing. Not in contrast, but probably more significant in its appearance would be something like alveolar syndrome. So alveolar syndrome is more consistent with a complete fluid overload within the lung tissue itself, and a complete loss in aeration or air within the alveoli. And we would see this most commonly in patients presenting clinically with pneumonia or with atelectasis. We can also see it in patients that are presenting with cardiogenic syndrome, so a fluid overload within the lung itself, but the distribution of the um, artifacts that we're seeing with the B lines can point us more towards a cardiogenic cause or more towards a pneumonia or infective type of cause. And we'll talk about that a little bit later in the presentation. So again, just as a reminder, the artifact patterns that are going to be most important in regards to identifying our interstitial or alveoli syndrome that we're really, really, really interested in is the B lines. And B lines, again, are very defined and laser-like vertical lines that are going to be generated from that pleural line, and they're going to extend all the way through our echo picture or through our ultrasound field, and they're going to move with the movement of the pleural line. Sometimes this might not be a lot of movement because the pleural line itself might not be moving very much due to the changes in the aeration pattern or the consolidation type of appearance that we'll see. But what we need to make sure is that when we're visualizing the B lines within one of the interstitial spaces, we're making a note of the quantity and the quality of the B lines. The more vibrant, the more apparent those B lines are, the more of a difference between the air and the fluid content within the lung, with it moving towards more fluid within the lung and less air within the lung, the more vibrant those B lines are. So, in regards to our interstitial syndrome, if we focus on interstitial syndrome just a little bit, so the amount of pulmonary edema that is located within the lung tissue itself, just because we're visualizing the B lines, it's just telling us that there's a change in the density within that lung itself, with more fluid being in that lung, the more B lines that we're seeing. Remember, one or two B lines within a lung field or intercostal space can be very normal and doesn't indicate any pathology. The higher the increase in B lines that you're seeing, the more dramatic reduction in the amount of air that you're seeing within that actual area. What is important is that we start to try and think about it and identify that distribution of the B lines that we're visualizing across the entire lung field. And this is where having a systematic exam becomes really important, because it can help to guide you towards some of the known causes of the B lines that we might be seeing. Just to remind everyone that B lines are equivalent to what you might find in a chest X-ray. Your curly B lines that you'd be seeing. So in a chest X-ray, if you're looking at a plain film X-ray, the higher number of B lines that you're seeing within that space, the higher fluid content within that space. The table that I've presented here, I think is interesting because one of the things that we're going to look at within this is the difference that we might find between a infected type of B-line presentation or interstitial alveoli syndrome presentation, as opposed to a non-infective or cardiogenic type of presentation that we might see. And you'll see from the table here, this is actually a really nice table that was presented by one of the cardiologists, the Italian cardiologist who uses lung ultrasound quite a lot, and presenting the differences that you're going to find in the distribution and the areas of consolidation that you might see. So if we work our way through this table just a little bit, with any of our interstitial or alveolar type of syndrome, the presence of lung sliding should be normal, or if anything, reduced due to the level of fluid within that lung. Under the cardiogenic pathway, if you're looking at a patient who's presenting with fluid overload or interstitial syndrome within the lung itself there, the distribution of the B lines that you're going to be seeing is going to be more of a homogeneous spread of the B lines within the dependent lung regions that you're visualizing. So you might find that you've got a clear lung sliding at the apexes of the lungs, anterior and posteriorly. They might look like relatively normal appearance with lung sliding, whereas as you move lower down in the chest, in the thoracic cavity, into more of the dependent lung regions, you'll see that the lung fields themselves are going to change their aeration pattern with an increase in the level of B lines that you're visualizing. But that distribution should be equal from right to left if you're looking at more of a cardiogenic pathology that's going on underneath. If we look at the opposite side of that, in regards to, for example, our ARDS type of pathology, which we might see quite a lot within our ICU setting, the movement of the pleural line, it can be reduced. It can be normal in some areas, but reduced or absence. But what's really important is the visualization of the pleural line in this instance, because we might find that the visualization of the pleural line is going to be irregular or thickened. I've got some nice pictures that we can show you a little bit later where it makes a little bit more sense. Also, the distribution of, for example, the B lines that are arising from that pleural line is not necessarily going to be homogeneous in the same way that you would see it in, for example, a cardiogenic pathology. You're going to potentially have, with any type of infected pathology, you've got areas where you've got an increased number of B lines and increased dependency of the fluid or infected process that's going on within those areas. And then you might have other areas that look relatively normal. You're more likely as well to find that you've got consolidation within your dependent lung region, so down towards the diaphragm. And even so, finding that there's areas where you've got even the diaphragm isn't moving as well because you've got that thickened, really densely consolidated lung at the bases. I've mentioned a few times about lung aeration. So if we consider the degree of lung aeration, this is really just to show you, I guess, more about probably more people would be more comfortable in visualizing chest x-ray and identifying what is good aeration or bad aeration. Not that you would necessarily want to have any of these lungs that we're seeing on the screen, but you can see that there's a definite and distinctive difference in the patterns of aeration within these lungs that we're seeing, or the degree of aeration that we can identify within these lungs. With the least aerated lung, the most white out, you can see that there's ECMO pipes going in there anyways, because otherwise how could he breathe? But the other, you see a gradient between the two. I just wanted to show you kind of what this would look like if we were looking at it precisely from a B-line distribution within these lung fields itself. So it might look something like this. Where we're seeing the difference in the, let's make sure that these will play for us as well. So we're seeing a difference in the aeration of these lung fields and the quality and consistency of the B line, where if we start with the best aerated lung field itself, you're seeing some movement of the pleural line, and you're seeing some laser-like appearance of the B lines that are being generated with no clear indication of A lines there, showing that there's a more of a B profile that we would be visualizing. Whereas if we look in the lung in the middle, where you've got poor aeration or very poor aeration, you've got, again, the B lines themselves are more distinctive. They're brighter in appearance. The pleural line itself isn't moving very well, but you can see that the B lines are moving and being distributed with, are being moved with the lung, the pleuris lining itself. Again, the whiteout appearance of the lung tissue underneath, it's more gray, and there's definitely no indication of any A lines that you might be seeing within this area. With the final picture that we're seeing here, it's almost a consolidated type of appearance. There is some movement of the pleural line with respiration, but the quality and the visualization of that pleural line is very much reduced, and the B lines seem to have merged together all into one, where you've got this almost like whiteout appearance. Interesting as well, you can see some air bronchograms underneath there, the little white speckled consolidated type of appearance, where we're visualizing more of the tissue type of appearance. And I've mentioned before about this pattern of aeration. So as we move through the field of the aerated lung, where we would potentially be visualizing, for example, our A lines as just a reflection of our aerated lung, that's where we're going to be at our 100% aeration or even over aeration of the lungs in something like a COPD type of patient, but it's going to give you a really nice visualization of those reflective artifacts that we're seeing. As the air content of the lung decreases and the fluid content of the lung increases, we're seeing this increase in the visualization of the B lines and the whiteout type of appearance, similar to what you would see on a chest x-ray or plain film x-ray. You get that same type of feeling of that whiteout appearance that you're seeing until you can get to a totally de-aerated lung, a consolidated type of lung, where you're directly visualizing the lung tissue itself. So just back briefly to that cardiogenic versus that infective type of ARDS type of pathology. I mentioned before about visualization of the pleural line. So it's not just about the distribution of the B lines within that tissue itself, but if we look at one of the most important features, if we look at the pleural line itself, because that's, again, where all of our lung artifact is generated from, it's going to help to guide us as well towards a clinical suspicion or a clinical diagnosis of maybe some of the pathology that's going on underneath there. So again, this is from our Italian cardiologist friend Luna Gargangi, who, it was in her presentation as well. So about looking at the subpleural alterations that you might visualize within this interstitial or alveolar type of syndrome that, again, can be used as more evidence to guide you towards the clinical suspicion of what's going on. This makes some good reference to some subpleural consolidations, and the visualization of the pleural line can look more bumpy, I guess is the best way of explaining it. So almost leading you towards a suspicion of that infected type of pathology that's going on underneath within the lung tissue itself. So it's not just the generation of the B lines that we're interested in this case. It's also the alterations to some of the landmark features, the pleural line in this case, that we're looking at that can help to guide us towards some of those suspicions. Whereas in an acute kind of cardiogenic or fluid overload pulmonary edema type of pathology, visualization of that pleural line is still going to be very clear. The combination of the opposition there of the visceral and the pleura or pleura are still going to give us that really bright white hyperechogenic line that we're used to seeing in our normal lung tissue patients. In real terms, I think this is probably a good this is probably a good view that can give you some of that further indications. It's almost impossible to see the pleural line within this type of infected type of ARDS pathology that we're seeing here. We are seeing quite clearly that this is the that we are on axis with the lung field, because we're seeing very nicely the bat sign that we've mentioned as one of our key indicators of making sure that you're on the right place. But you can see that pleural line, you've got that subpleural consolidation that's butting up against the chest wall itself, so indicating a very infective or consolidated, not consolidated because it's moving in this case, but a very wet lung itself. So complete loss of lung aeration here, and infected type of appearance that we might see. As we move further along the spectrum of that consolidation in that infective type of appearance, you might also visualize what we call air fluid bronchograms. Which are just here. So you can see that both of these pictures that I've just shown you just here are from our ECMO patients that have infected pathology going on underneath. And it's very clear to see that you're directly visualizing the lung tissue itself. You've got that really consolidated, thick, dense lung that almost looks hepatic-like, so it looks like a liver itself. But in this picture, as opposed to the previous picture where I was showing you that infected pathology that we can see even up to the pleural line itself, in this picture we're seeing more of the result or the consequence of that infected type of appearance down at the lung basis. It's interesting to see if we think back to that table that I was showing you at the beginning of this presentation. We were looking before to say that in a cardiogenic type of appearance you would potentially see pleural effusions, but in an infective ARDS pathology you're not seeing the same level of effusions that you might see here. And in this case it's very clear to see that there's just a very thin rim of fluid around the lung, but that lung is filling up that thoracic cavity and it's completely consolidated. The movement of this patient is obviously ventilated or lung protected ventilated, because with the ventilated breast that we're seeing this bright flash of the air within the bronchograms themselves. So it's giving us a very dynamic view of what's going on underneath, which is something that we definitely can't see in the other imaging modalities that we're going to see. Even in our CT. And here's just, again, another visualization of those air fluid bronchograms, the dynamic movements, and you've got some referred movement here with the, you've got some referred movement from the heart from behind as well. So I'm sorry it was a bit quick. I just wanted to make sure that I had covered the interstitial syndrome within this lung ultrasound presentation. Just as final thoughts, just making sure that when we're considering our interstitial syndrome or alveolar syndrome, think back to that graph that I was showing you before that gives you a systematic, making sure that you're undertaking systematic reviews of the lung field itself, and trying to include as many of the lung areas as you can, and making a note of the distribution and the quality of those B lines from right to left, and the quality of some of the landmarks that you might see within the lung field. So looking at the pleural line and looking for any dynamic movements or air fluid bronchograms that you might be seeing. So I think I am just about on time. If anybody has any questions or wants to go over anything else, then I am more than happy to answer any questions.